My name is Reem, consultant radiologist and head of medical imaging department in Chest Disease Hospital. I'm presenting cases of COVID-19 pneumonia. At the beginning, I'd like to thank the Dr. Buthain Al-Kandari, the head of medical imaging department in Jaber Hospital, and her PACS team for providing the images and the slideshow from their PACS system. The objectives of my talk is the role of imaging in COVID-19 pneumonia, imaging modality and imaging feature of COVID-19 pneumonia. We'll talk about COVID-19 pneumonia report templates, and we'll close up with incidental imaging finding in the era of COVID-19. Role of imaging. Chest imaging is important in diagnostic workup. Chest imaging play a role when PCR is not available, or there is a delay in PCR result in a suspected cases, or when the physician received a negative initial PCR in symptomatic patients. We'll present the WHO recommendation and the Fletcher Society statements. There is a small manual and available online. WHO present 6 recommendations based on patient clinical status, ranging from asymptomatic patients to severely ill patient up till the time of discharge. And I summarized it in this small flow chart, but you can read the detail online. Recommendation number 1 apply to asymptomatic patient when they recommend that there is no rule for imaging and no need to do any chest x-ray. If the PCR is available, the patient need self-monitoring. Recommendation number 2 applied on symptomatic patient. Again, there is no rule for imaging when the PCR is ready and available, and we need a chest x-ray or further imaging such as CT chest if the PCR is not available, or there is delay in the result, or we got a negative result in the initial management. Recommendation number 3, 4, and 5 based on the patient's symptoms, and it's important whether to send the patient for home quarantine versus admit the patient to the hospital in case of having a mild symptoms, or in recommendation number 2, differentiating the patient symptom severity while to keep them in the ward or send them to the ICU for better and higher care. And recommendation number 5, the imaging is important in therapeutic assessment while following the disease course during hospitalization. Imaging modality. Chest x-ray, CT chest, and ultrasound are used. Chest x-ray is a quick modality that detects the abnormality, leads to isolation of the suspected patients and control the outbreak. Chest x-ray useful in monitor clinical course and evaluate the disease severity. It's useful in the follow-up and easy to repeat while using the mobile unit. Again, it has a low radiation dose. However, the disadvantage of chest x-ray being insensitive in area of the disease. 18% of chest x-ray turn to be normal in early disease, and the most extensive finding appear in the chest x-ray 10 days after the initial presentation of the symptoms. CT can play a role in patient triage, especially when there is a lack of PCR. CT can predict disease worsening and assess patient's improvement. And CT is a great problem solver in suspecting complications such as PE. CT scan as a screening tool and diagnostic tool completely refused by Fletcher Society, and that is because of its low specificity, plus the COVID-19 imaging feature can overlap with other imaging finding in other viral pneumonias. Additionally, there is a radiation hazard of using CTs, plus a prolonged scan time compared to a quick and fast portable chest X-ray. There is a risk of viral transmission while moving the patient through the healthcare institutes, and this might affect the healthcare worker plus the patient, other patients as well. Personal protective equipment consumption, it has a limitation, and cleaning and downtime of the CT room according to infectious control guideline and policy, and this may take around 1 hour while we are scanning the patients. Plus, COVID-19 testing is a must, even if we saw any suspected finding on imaging related to COVID-19. Ultrasound also is useful in resources limited setting. It's low cost, non-ionizing radiation, and it's really helpful as a point of care in ICUs, and can detect peripheral subpleural consolidations, which is the mark of COVID-19 pneumonia. However, it's an operator dependent, plus we need to admit that we have a limited experience in using ultrasound in evaluating lung parenchyma. Plus, there is an infectious control issue in cleaning and disinfecting, similar to CT. Summarizing a Fletcher Society recommendation, imaging is not routinely indicated as a screening test for COVID-19 in asymptomatic patients, and this is similar to recommendation number 1 released by WHO, or in patients with mild feature, unless they are at risk of disease progression. Imaging is indicated for patients with moderate to severe disease, regardless of PCR results, and worsening respiratory symptoms might be an indicative to do a further imaging for better patient's care. Chest X-ray, it's preferable unless feature of respiratory worsening warranted to do a CT. Imaging feature. Both chest X-ray and CT shows more or less similar finding. In chest X-ray evaluation, we can see a finding of atypical pneumonia or organizing pneumonia. That is an aerospace disease scattered in both lung, bilateral, peripheral, and subpleural. A CT scan, mainly in the early stage of the disease, will show ground glass opacification. Classically, it's a peripheral and bilateral and involving multiple lobes. Probable COVID-19 infection, this is the abnormalities or the ground glass opacity will appear in a central area rather than being at the periphery. Again, crazy paving, that is a ground glass with septal thickening, is mentioned, as well as a consolidation. Rare feature like a cavity, nodules, a tree and bud, lymph nodes, a pleural effusion can be seen as well. This is a 45-year-old male presented with respiratory symptoms, tested positive for COVID, and we can see a classic mild changes. This is what we call it a peripheral subpleural aerospace disease, minor atelectasis on the left lung with small nodularities at the center of the lung. Follow-up chest X-ray 10 days later shows a disease progression with involvement of the upper lobe and extent of the abnormality in the upper lobe. This is a follow-up with the negative exit swab showing a complete recovery with no residual. This is another case testing for COVID positive, and he's an ICU patient when we can see a central line, and the chest X-ray shows severe aerospace disease with almost white out lung. Follow-up chest X-ray is indicated to assess and monitor the patient progressive and regressive course, and we can see that disease is progressed in over a period of 5 days, and 1 week later, patient is gradually improved. This is his complete clear chest X-ray 1 month after his first presentation. Regarding the CT, again, it's an important modality, diagnose and support in diagnostic COVID-19 pneumonia. This is a 50-year-old male symptomatic patient, has a history of contact. His wife recently came back from the UK and tested positive. His swab was equivocal and his chest X-ray was completely normal. And according to WHO recommendation, you need to know whether you send this patient home or you admit him. CT was done and it showed a typical finding of COVID pneumonia, bilateral, scattered ground glass opacification, and it's mainly seen along the peribronchovascular distribution. In non-COVID era, we can consider another differential diagnosis such as atypical pneumonia, especially Haemophilus influenza, and atypical sarcoids also can present on CT with similar findings. Another patient, age 65, referred from a private hospital. He was symptomatic with fever and normal chest X-ray. You can see a ghost opacity with a mild atelectatic band in the left lower lung. And again, we want to know whether to admit this patient for better care or send him for home quarantine. CT was performed and it shows a typical bilateral peripheral subpleural ground glass opacity and area of grazy paving and septal thickening involving both lung and multiple. And this is a coronal image which shows the diseases involving the upper lobes. Another severe case, ICU patient with ARDS, nearly complete white-out lung with severe respiratory symptoms, warranted to do a further imaging and further follow-up with chest X-ray to assess the therapeutic response. A short or a brief about ARDS. It's an acute hypoxemic state. The pathology related to infiltration of a protein-rich edema sometime may progress into a fibrosis. And the pathophysiology of ARDS is the ratio of arterial pressure to fractions of inspired oxygen is reduced less than 200 millimeter per mercury in a moderate stage. If it's less than 100, then it will be a severe stage. Regarding the images, chest X-ray will show diffuse bilateral lung opacification, and the CT will confirm this opacification. And in ARDS, we will see a consolidation in the dependent or gravitation area, and the ground glass opacity will be in the non-dependent area, as in this image. Follow-up post-discharge after treatment and getting a negative swab, the patient's chest X-ray turned to be a completely normal with no significant no residual fibrosis as well. Additional recommendation for imaging regarding these critical cases or ICU patients, daily chest radiographs are not indicated in a stable intubated patient with COVID-19. A study shows that repeated chest X-ray doesn't change, there is no change in morbidity or mortality with the frequently repeated chest X-ray. And CT scan is indicated in patients with functional impairment and or hypoxemia after recovery of COVID-19. And this is to assess the patient for post-ARDS fibrosis. Another feature of COVID-19 pneumonia seen in this young male patient who he's symptomatic, with tested positive, and his chest X-ray also was positive, showing a lobar pneumonia in the right lower lobe. Physician requested a CT, and according to the recommendation, CT is not indicated because we have positive symptoms, positive swab, and positive chest X-ray, and it's more than enough to proceed and continue treating the patient and monitor the patient response with only repeated chest X-ray. On the other hand, this is a similar age patient. He's 30 years old, symptomatic healthcare worker, one of our colleagues working in one of Kuwait quarantined. His swab came equivocal, and his chest X-ray also was indeterminate, and we can see a ghost opacification in the left lower lobe with a band-like atelectasis, and we were not sure if this is a true lesion or this is related to position or exposure factors. CT was performed because really it was justified, and it revealed lobar pneumonia in the left lower lobe with air bronchogram and the ground examination. And if you didn't believe in this opacity, now you know that it was a true opacity, since the follow-up chest X-ray after the discharge was completely clear. Regarding reporting system in COVID pneumonia, it's a categorical assessment scheme for pulmonary involvement of COVID-19 on an enhanced CT chest in suspected patients. There is an inter-observer variation, and there is a difference in experience while interpreting such cases. So I found this CORA prolonged and sophisticated. Honestly, I didn't use it, but it's worth mentioning, and it's worth going through it.
Dr. Reem, the time, please.
Oh, sorry.
1 minute, please.
Okay. This is another European radiology. A nice figure was released in literature showing the different stages of the disease, where it can start with the ground glass opacity, ends up with ARDS, and it's not uncommon to see for minor residual on imaging post-treatment. Symptomatic patient tested positive with incidental finding on the right paracardiac area with the differential diagnosis. This is recommendation number 6 by WHO. You need to investigate this incidental finding before you send the patient home. CT was justified. Patient was labeled as carcinoid and sent for thoracic surgery. Another incidental finding, reticular pattern in positive COVID patients. ILD ruled out, and the patient turned to have an hypersensitivity pneumonitis after the clearing hair infection. These are all CT. And one final important case I want to show you from the ICU. It's an ARDS, complicated cases with air leak and tension pneumothorax. Chest tube was inserted, patient improved. However, a week later, the patient developed an unusual large opacity in the right upper lobe with a listed of differential. This could be consolidation, effusion, and empyema hematoma. CT was justified and showed a large hematoma in the right upper, and this was followed conservatively. In summary, a role of imaging in COVID-19 pneumonia based on a clinical scenario according to updated WHO recommendation and the Fletcher Society statement. In a resource-constrained environment, imaging is indicated for a clinical triage. However, negative imaging doesn't rule COVID-19. Chest imaging help in the diagnosis when PCR is negative or equivocal. Chest imaging play a role in monitor and follow up disease, adding extra information regarding disease complications. And thank you very much.